Good morning, my dear students. So let us come back to the second part of the drugs actually modifying thyroid metabolism. So these type of drugs can be classified into two types: those which are actually having action on hyperthyroidism, or those are called thyroid drugs, and some drugs which are basically effective on hyperthyroid state, and they are called antithyroid drugs. So, well, let us start with the thyroid drugs, which includes levothyroxine, which is basically present in the oral form, that is T4 hormone, which is not the active form, but the active form, which is T3 liothyronine, which is also available in the market, and there is a combination of the both, it means T3 and T4, which is also available for use in different conditions. Even in different emergency conditions, which you have heard in the previous presentation, that in mixed edema coma, probably you can use injectable form of this liothyronine T3 form, or even a combination of T4 with T3. But normal hypothyroidism case is usually treated with only T4 hormone, that means levothyroxine, and these type of problems are known as hypothyroidism. So hypothyroidism can be happen due to different reasons. There may be subclinical hypothyroidism, which where you will see that without symptoms, having normal free T4 but higher TSH level. There may be problems in case of these hypothyroidisms, where the patient is probably not presenting with much of the symptoms. Sometimes they are presenting with symptoms like overweight, fall of hair, and all these things. And in those cases, you can simply prescribe T4 hormones, and obviously you will go for antibody test. That I mean the rules you have to follow while prescribing the T4 hormone is the patient has to take it in empty stomach, and in the morning. It should not interact with food or any other drug. So you must be very careful regarding this matter. The pharmacokinetics is already been mentioned over here, that it is easily absorbed and bioavailability is around 80%, whereas in case of T3 is 95%, but T3 is more sensitive towards cardiac myocardium, and hence especially the cardiac cells, and hence the chance of cardiac arrhythmia is more with T3. So we used to avoid T3 unless there is any specific indication, though T3 is basically an active hormone. We will prefer T4 for the treatment of simple case of hypothyroidism. In case of goiter, iodine deficiency, you can, in the endemic goiter, is a manifestation of iodine deficiency, and there you have to treat it with the required iodine, which is basically 1 to 2 microgram per kg of body weight, and that can be made with by ingestion of 200 gram of sea fish 2 to 3 times a week. A treatment of pre-existing simple goiter with iodine is generally unsuccessful, and in those cases, even in endemic goiter, we may have to treat the patient with T4 hormone. This T4 hormone or T3 even, they can induce hepatic microsomal enzymes, and hence the you will see that rifampicin, phenobarbital, phenytoin may improve their metabolism. But as I said, it is always better to avoid interaction with any other drug. So the indications are the hypothyroidism, especially if it is happening at the childhood, the cretinism. Ideally, it should be given before affecting your brain, even before development of brain. Then if you start a hormone early, the chance of having damage is minimal. So it's always better to prescribe hormone, measure the hormone level from the pregnancy onwards, and if you see there is deficiency, you have to increase the concentration of T4 hormone even during pregnancy and following pregnancy to the fetus. So in hypothyroidism, in simple goiter for pathogeny remaining unclear, the endemic goiter directly supply iodine, and in others where you may see that adverse reactions sometimes lead to thyrotoxicosis or sometimes angina or infarction, which is very common with T3 hormone, not with the T4. So these are little bit about the drugs, the main drugs used in hypothyroidism. So there is another group. The group is called the antithyroid drugs, and these drugs are commonly useful in hyperthyroidism. The clinical manifestation of hyperthyroidism are due to an excess of circulating thyroid hormone, and they can be ameliorated by using antithyroid drugs. These drugs which basically interfere with hormone synthesis. There are iron inhibitors which inhibit iodine trapping and binding, potassium perchlorate, thiocyanate. There are thioamides which is being mentioned over there. These are the main group of drugs which inhibit thyroid peroxidase and block the synthesis of monoiodotyrosine and diiodotyrosine and prevent the coupling reaction. And these examples are propylthiouracil and carbimazole. Out of this, propylthiouracil usually doesn't cross placental barrier and hence safe in pregnancy, whereas carbimazole is also not causing that much of damage, but aplasia cutis is one of the side effects or adverse drug reactions of this drug. Hence, we will prefer propylthiouracil over carbimazole in pregnancy. Other than this, propylthiouracil also inhibits the conversion of T4 to T3, that means the non-active to active hormone during thyroid storm. So in thyrotoxic crisis or in thyroid storm, you will always prefer propylthiouracil because it will prevent the peripheral conversion of T4 to T3. There are some drugs which interfere with hormone release and promote its storage. Those are iodides and lugoliodine. The lugoliodine has its function. It will have a contractile property. It constricts the blood vessels, and therefore the thyroid, the tumor or the things which is required for surgery, that the gland itself, thyroid gland, becomes firmer and the chance of hemorrhage is less, and as well as this will prevent the chance of thyrotoxic surge or release of thyroid hormone following surgery. So this is the reason why Lugos iodine or the iodine as a whole or potassium iodide is used not only during thyroid crisis or thyroid storm, it is also used before surgery to prepare a patient. It is usually given 10 to 14 days before thyroid surgery. And lastly, it's coming the radioactive iodine, which has two kinds of particles, beta and gamma, and these destroy the acini, and one part of this is used for diagnostic purpose. So these are in little bit about the drugs used in hyperthyroidism, or these are the drugs which are called antithyroid drugs. So thiamides are the most important drugs belonging to this group, and the methyl and propylthiouracil, methimazole and carbimazole are the preliminary drugs. They have similar modes of action, differ in their pharmacokinetics, dosage, and the incidence of different adverse drug reactions. The basic mechanism lying on the fact that they are preventing coupling of iodotyrosines, they are preventing the formation of monoiodotyrosine, and they are also preventing the conversion of monoiodotyrosine to diiodotyrosine. Propylthiouracil, in addition, inhibits the peripheral deiodinase and prevents conversion of T4 hormone to T3. Hence, carbimazole has also been claimed to encourage a remission in Graves' disease by suppressing the autoimmune process in the thyroid. Is not encouraged in case of thyroid storm. In thyroid storm, we will always prefer propylthiouracil. The anti-TSH receptor antibodies are usually decreased, and the circulating suppressor T cells some are basically going to be increased. Now these drugs are rapidly absorbed after oral administration and they are concentrated by the thyroid gland. The duration of action of a single oral dose is usually less than 8 hours, but they are administered every 6 to 8 hourly. Some physicians, however, prescribe the entire daily dose of thiamides on a once a day basis. They are partly metabolized in the liver and excreted in the urine in the unchanged form. Carbimazole is metabolized to the active metabolite methimazole. The plasma T-half of propyl thyrosol is around 75 minutes, whereas in case of carbimazole it is 4 to 6 hours. And as I said, propyl thyrosol usually doesn't cross placental barrier, whereas the other one is usually crossing it and is also secreted in milk. So on the basis of that, propyl thyrosol is a safer drug in case of pregnancy. So all thiamides inhibit peroxidase catalyzing reactions, iodine organification, iodothyrosis condensation. Propyl thyrosol inhibits T4 converting to T3. That means the peripheral conversion is stopped by propyl thyrosol. Hence, it is absolutely indicated in case of thyroid storm. So, as I mentioned, it's the first choice of drug for thyroid crisis. These are basically appear slowly, and in 2 to 3 months the basic metabolic rate is normalized. Long-term use may lead to thyroid hyperplasia. Methimazole is almost 10 times more potent as propyl thyrosol. So in that sense, methimazole is a fast choice drug if there is no such relative indications like pregnancy or if the patient is not having thyroid toxicosis. Always you will prefer drug like methimazole over propyl thyrosol. So in some places propyl thyrosol is scoring over methimazole, and in some other places you will prefer methimazole over propyl thyrosol. Methimazole causes aplasia cutis, that is one of the adverse drug reactions happened during pregnancy to the fetus. The preparations are available in different forms, and like the propyl thyrosol 50 mg tablets are available, whereas in methimazole 5 to 10 mg tablets are available. The milder adverse drug reactions are drug fever, pruritus, urticaria, edema of the feet, lymphadenopathy, hair loss. So these are very common adverse drug reactions. Most serious effects are thrombocytopenia, leukopenia, liver damage, and rarely agranulocytosis. The patient should be told to report any attack of sore throat, fever, and oral ulcerations during therapy, which is basically suggesting neutropenia. And hypothyroidism is an extension of the pharmacological action of these drugs, which is basically reversible. Clinically, these kind of thiamide drugs are used in case of mild hyperthyroid and those with surgery, and where the 131I, that means radioactive iodine, is not permitted, especially in pregnancy. Operational preparations, you have to prepare, as I mentioned, with glucose iodine and these type of drugs at least 14 days before thyroid surgery. Otherwise, the release of thyroid hormone may lead to thyroid storm and in thyroid crisis. So in those cases, you have to select thiamide group of drugs. So long-term use leads to thyroid hyperplasia, pruritic maculopapular rash, and the most dangerous side effect is agranulocytosis. So whenever there is a problem of sore throat, patient should report to the doctor, the consulting clinician. The iodides is the oldest remedy for thyroid disease, and it including hyperthyroidism. It is the quickest acting drug in hyperthyroidism, and its action becomes apparent within 24 hours. The BMR falls at a rate comparable to that seen after total thyroidectomy. The acinar cells become smaller in size and the colloid content increases. The gland becomes less vascular and firm. Maximal clinical benefit you will see within 10 to 14 days. The hyperthyroid state is, however, partially controlled by iodide and after a variable period of time, and beneficial effects seem to wear off. The mechanism of this iodine is lying on the fact that Iodine rapidly shuts off the release of the preformed thyroid hormones and promotes their storage. This effect is called thyroid constipation, is availed of while using iodine in the management of thyroid crisis. It inhibits synthesis of iodotyrosine and iodothyronine, and that is called Wolff-Chaikoff effect. This is due to high intracellular concentration of iodide. With time, there is an escape for this effect. It limits its own transport, resulting in low iodide levels. When given along with thiourea compound, it prevents the increase in size and vascularity of the goiter that can occur following antithyroid drugs. The common adverse drug reactions are basically they're intoxicating in the susceptible individuals, leading to skin rash, rhinorrhea, lacrimation, increase in salivation. So, iodide causes of escape of thyrotoxicosis is if used in a patient on potassium perchlorate. Prolonged use of iodides has been reported to occasionally produce goiter and even myxedema. Iodides may cross the placenta, may cause goiter in the fetus. They must therefore be avoided during pregnancy. They may precipitate thyrotoxicosis in an occasional patient with a non-toxic goiter, especially in iodine deficient areas, and this is basically known as Jod-Bezdow effect. This effect has been occasionally reported also after the use of an iodine containing organic dye as for coronary angiography, as well as after the antiarrhythmic drug amiodarone. So, amiodarone may cause these type of thyrotoxicosis. Actually, amiodarone is responsible for causing both hypo and hyperthyroidism. Different doses are available. The mostly we are preferring saturated solution of potassium iodide and leucothione. Saturated solution of potassium iodide is known as SSKI. It is abbreviated as SSKI, and these are very much preferred in case of thyroid crisis. So, the prevention of obviously they are used in operational preparations, thyroid crisis, preoperative preparations, the rapid control of hyperthyroidism, blocking the thyroidal uptake. So, these are in brief about sodium iodide and potassium iodide. Ultimately, we are coming to the last drug from the group of antithyroid drugs, that is the radioactive iodine. 131I is basically concentrated selectively by the thyroid gland. It emits both gamma and beta radiations. Gamma radiation is used for measuring radioiodine uptake and for thyroid scan, whereas beta radiation is particles that penetrate only up to 3 to 5 millimeter in the soft tissues, and within this compass they dissipate their energy and act as ionizing radiation. They selectively destroy the thyroidal follicles, produce fibrosis and impair the ability of the remaining follicles to replicate. The preparations are available in different forms, like sodium 131 iodine, which is administered orally in the dose of 3 to 10 millimercury on an empty stomach and after a light breakfast, whereas patients can be treated on an outpatient basis but are instructed to dispose of their urine carefully into latrine to avoid close contact with children for 2 weeks. The effect of a dose becomes apparent within 3 to 4 weeks, with maximum effect by 3 to 6 months. About 50% of the patients become euthyroid after a single dose. Others may require second, even a third dose. So, the decision about needing the second dose is usually taken at the end of 4 to 6 months. The common adverse drug reactions which we are seeing, that the focal soreness in the neck due to irradiation, transient aggravation of the hyperthyroid state, hypothyroidism, damage to the fetal thyroid. The fetal thyroid picks up iodine. It is absolutely contraindicated in pregnancy. In thyroid carcinoma, where the radiation is known to be carcinogenic, and the possibility of development of thyroid cancer following radioiodine cannot be totally ruled out. So, these are all adverse drug reactions of this 131I, and it may lead to genetic damage. This has not been so far not been demonstrated in the clinical, not in the clinical trials, rather in the clinical practice. The treatment, we are going to finish this presentation with the management of thyroid storm or thyrotoxic storm, thyroid crisis, where you will see the manifestations of extreme hypermetabolism in a thyrotoxic patients, and it is usually occur after thyroidectomy in an inadequately prepared patient, which is called surgical storm. If it is happened in presence of infection, injury, or any surgical procedure other than thyroidectomy, it is called medical storm. But both of them are storms, and both of them should be treated in a similar manner. Now, in case of the treatment of thyroid crisis, you will hospitalize the patient, preferably in intensive care unit. The treatment of the precipitating cause should be done. Large doses of the antithyroid dose like propylthiouracil is usually preferred because it inhibits peripheral conversion of T4 to T3. And 200 milligram of the dose is given, or carbimazole can be given if this propylthiouracil is not available. Iodide, that is the iodide form, started a couple of hours after the thiamide drug, that means propylthiouracil. It may be given intravenously in the form of sodium iodide or through a nasogastric tube. These doses are in excess of that which controls hyperthyroidism. You have to prescribe a beta blocker, which is written here, and preferably it is propranolol, because that has the property to also prevent the conversion of T4 to T3, that is active hormone. Not only that, these this non-selective beta blocker has anti-arrhythmic effect. Supportive measures like include, the use of dexamethasone, which is a steroid, 0.5 to 1 milligram, 8 hourly, oxygen, adequate intravenous fluid, glucose, B-complex vitamins, if possible antibiotic or other antimicrobials, and the treatment of hyperpyrexia with paracetamol and tepid sponging may be essential during these kind of problems like thyroid storm. And heart failure, if present, needs to be treated with different drugs like digoxin, or the drugs like the beta blockers, as I mentioned, propranolol, some drugs like diuretics if it is absolutely essential, spironolactone. So those drugs may be given to treat a case of failure, heart failure due to thyroid crisis or thyroid storm. Aspirin should be avoided as it can displace thyroid hormone from its binding proteins. So these are in brief about the discussion on thyroid, antithyroid, and the drugs used in hypothyroidism. And before concluding, I am just mentioning few of the advantages and disadvantages of using radioactive iodine, which is very much essential in today's practice. So the radioactive iodine is basically the treatment is convenient, effective, and carried out on an outpatient basis. It is pleasant to take without any discomfort and fear. There is usually generally no fear of recurrence, relatively inexpensive and safe, and it can be offered to patients in whom surgery is not possible. Whereas the disadvantages are it causes high incidence of hypothyroidism. It cannot be given in a woman of the childbearing age without ascertaining whether she is not pregnant. It is slow acting. Follow-up for several years is necessary. And lastly, the special facilities for handling the radioactive material is necessary. So these are the common disadvantages of radioactive iodine. The surgical procedures are only required where these drugs are not going to be effective, and the surgical procedures are mostly indicated in multinodular toxic goiter, solitary toxic nodule, a large diffuse toxic goiter, in recurrence after adequate treatment with a thiamide group, that means the propylthiouracil or carbimazole, and when malignancy cannot be ruled out. So these in brief about the drugs, different drugs used in different types of thyroid disorders. Thank you so much for your kind attention.